Hello everyone. My name is Dr. Aditi Bhat. I'm a faculty at College of Physiotherapy, School of Health Sciences, Dayanand Sagar University. Today I would like to present a review on vestibular dysfunction and gait abnormalities, insights from current evidence under the guidance of Dr. Satya Guru Prasad. The contents of my presentation would include a brief background, need of the study, methodology which was adopted, gait deviations in vestibular disorders, and a summary of it. When we talk about vestibular disorders as a whole, it can be divided into peripheral and central disorders. The peripheral disorders which affect the inner ear or the vestibular nerve mainly include unilateral or bilateral vestibulopathies, Meniere disease, VPPV, vestibular paroxysmia, and superior canal dehiscence syndrome. Whereas central disorders mainly affect the vestibular nuclear complex, cerebellum, midbrain, and higher centers of cortical functions. And instability of this can lead to disturbance in the balance, spatial orientation, and a sense of motion. When we talk about the vestibular functions as a whole, it is responsible to maintain the balance, postural stability, gait stabilization, autonomic functions, and also regulates emotion, sleep, and cognition by the various reflexes and pathways such as VSR, VOR, vestibulocerebellar pathways, vestibulothalamocortical pathways, and also vestibulohippocampal pathways. If there's any lesion in any of the pathways or functions, can lead to unsteadiness, oscillopsia, hearing loss, tinnitus, postural imbalance, and a higher risk of fall. It's seen that patients with vestibular dysfunctions may have or at a higher risk of developing spatiotemporal gait disturbances, increased gait variability, and a heightened risk of falls, which are quite common. It uh, also translates to instability in step width, length, and timing, especially during fast walking or dual tasking. They also demonstrate increased variability and altered support strategies, especially while walking in conditions like eyes closed ambulations or cognitive distractions. Their reliance on vestibular feedback is paramount. Recent innovations in clinical gait assessment includes the concurrent dynamic visual acuity (DVA) testing and a motion capture analysis have enabled more nuanced detection of gait abnormalities in vestibular patients. Gait analysis has a crucial role in clinical evaluation of vestibular disorders, not only to quantify instability but also to uncover compensating mechanisms and guide individualized rehabilitation strategies. The existing literature presents variability in methodologies, population studies, and outcome measures, making it challenging to synthesize clear clinical implications. Furthermore, many healthcare providers may under-recognize gait disturbances as a consequence of vestibular dysfunction, leading to a delayed or suboptimal rehabilitation strategies. Thus, this review of literature presses the need of a comprehensive overview that synthesizes current evidence on gait deviations in vestibular disorders. For this review, we had reviewed databases such as PubMed, CINAHL, and Google Scholar for gray literature. The duration of study or inclusion of studies ranged between 2025 to 2011, since many of the classic evidences were found quite old. The type of studies which included was full text clinical trials, observational studies, and high quality reviews that address gait abnormalities in vestibular populations, with experts key terms such as vestibular disorders, gait deviations, gait analysis, vestibulopathy, and walking difficulties, which were used to identify the relevant studies. When we talk about the gait deviations vestibular disorder, we can divide into various subsections depending on what parameters or what components of the gaits are deviated. When you talk about spatial temporal gait variability, many studies show that patients with bilateral vestibulopathy they have increased cadence and step time is reduced, suggesting a compensating strategy to maintain dynamic stability despite vestibular disorders or deficits. It is also seen that there's a moderate effect size in step with variability, indicating potential challenges in unilateral stability. Further, the double support phase and walking speed alone was found to be a key predictor of anterior posterior margins of stability in patients with BVP. Double support phase is critical for redirecting the center of mass and integrating proprioceptive and vestibular inputs. And also, they will rely heavily on this phase to compensate for impaired vestibular functions and enhance visual and postural stability, highlighting a speed-sensitive nature of gait control in these patients. Amongst vestibulopathies, it's seen that patients with bilateral involvement have reduced gait speed, shorter step length, and increased step width, especially at slower paces, a pattern consistent with the cautious gait strategy to compensate for instability. They also have longer stance and double support time at slow and comfortable speeds, reflecting greater reliance on stable phases of gait. These abnormalities diminish at faster walking speeds, possibly due to reduced reliance on sensory feedback and increased mechanical stabilization. While variability measures reflect control precisions, they do not directly equate to dynamic stability, emphasizing the need for future studies to assess gait stability using dynamic metrics such as measures of stability. When you talk about just stability and balance control, the patients who have unilateral vestibular loss, they seem to have lateral veering or lateral pulsion towards the affected side, towards the side of lesion. Whereas bilateral involvement patients show more of anterior posterior instability leading to falls in diagonal or sagittal directions. They also have prolonged reaction time, longer gait initiation duration, and a shorter initial step length, and also show delayed motor planning and increased consciousness. They have altered center of pressure displacement patterns and reduced ground reaction forces, further suggest compromised anticipatory control. When we talk about EMG analysis, they show increased contraction of the anterior tibialis muscle and gastrocnemius muscle, reflecting increased joint stiffness, potentially reducing efficiency to gauge stability. They also show impairments in turning performances by having reduced peak and mean turn velocities and longer turn durations, indicating that dynamic tasks such as turning may better reveal subtle balance deficits. They also show higher oscillation speeds in anteroposterior direction, indicating impaired dynamic postural control. When we talk about influence of visual and vestibular influences on gait, it is seen that patients, when they were made to walk on treadmill, who have bilateral involvement, under concurrent dynamic visual acuity testing, they showed step length, step time, and double support time was significantly influenced by walking speed, with all parameters showing robust differences across speeds of 2, 4, and 6 kilometers per hour. The mean step width did not vary significantly with speed, suggesting a trade off between locomotor efficiency and stability at higher speeds. There was a modest increase in the double support time during deviate task, which is also noted possibly due to dual task interference, similar to effects observed in cognitive dual task paradigms. These participants to adopt a more cautious gait pattern. When there's a lesion specific asymmetry study done, it is shown that bilateral patients overall showed slower speed, shorter step length, wider step width, and increased variability, especially at lower speeds, prolonged double support time, and reduced turn velocity. Whereas when the patients were made to walk at a faster speed, the improvements were seen in the gait parameters, maybe due to reliance on the automatic motor programs. In unilateral infected patients, there was asymmetric gait, delayed initiation, shorter steps, and delayed medial lateral sweep, reduced anticipatory muscle activity, and prolonged reaction times, which are very evident. Another study was done where the vestibular migraine patients by Powell et al., also in central disorders, showed marked by poor gait coordination, increased side variability, and worsened under sensory challenges or dual task conditions. In patients with benign thoracic positional vertigo, they showed reduced velocity, cadence, and stride length, especially during head movements or dual tasking. Chronic peripheral vascular patients featured slower gait, increased anterior posterior sway, and shorter steps, often linked with cognitive decline, affecting gait planning and control. Whereas patients with post-acute vascular stroke, leading to slower gait, prolonged double support, and mixed ataxia. Gait may be relatively preserved compared to peripheral causes depending on the lesion size. When the patients were given dual tasking, with a motor and a cognitive component, they had shown impaired sensory integration and reduced cognitive reserves. Pavlov, in the year 2023, conducted a study in patients with vestibular dysfunctions. They performed significantly worse in the items or components of functional gait assessment (FGA) under both single and dual task conditions. The dual task cost, reflecting the decrement in gait performance and cognitive loads, was markedly high in patients with vestibular dysfunction. Poorer FGF scores showed impairment in spatial working memory, rapid visual processing, and paired associate learning, cognitive functions linked to the medial temporal lobe and visual spatial perception. Vestibular depressive patients not only had difficulties in balance, but also it interfered with cognitive processing, making dynamic gait tasks more effortful and less automatic in this population. They also had rapid information processing, which showed as a key predictor for gait performance, indicating a stronger role for cholinergic pathways over dopaminergic pathways in dual task gait control. During dual tasking, these patients had 19% slower gait velocities than the healthy controls. They also show difficulties in eye closed walking, head movements walking, and also tandem walking. Collectively, these findings emphasize that dual task gait assessments are crucial for revealing subtle mobility impairments in vestibular disorders, and that cognitive motor interference may hinder rehabilitation outcomes unless specifically addressed. As summary of the uh, whole review, we can say that vestibular dysfunction significantly impacts gait performances through disturbance in balance, facial orientation, and also sensory motor integration. The current body of evidence highlights distinct gait deviations across various vestibular pathologies, with alterations in spatiotemporal parameters, dynamic stability, and dual task performance emerging as a key marker of functional impairment. Despite advancements in assessment technologies, inconsistencies in methodology and outcome measures persist, limiting the generalizability of findings. Thus, future research should aim to standardize evaluation frameworks and explore targeted rehabilitation strategies that integrate both physical and cognitive dimensions of gait control. Integrating such evidence in clinical practice to enhance diagnostic accuracy, optimal intervention strategies, and untimely improve mobility and quality of life in individuals with vestibular disorders. These are my references. Thank you.